So last time we were together, we talked a little bit about what sort of blood work we were doing, what sort of tests we were doing, and we're going to further that discussion right now on, okay, now we've got the results back. Now what do we do? So we'll go from there. So Dr. Reese laughs at this. This is my clown hand. Anybody that was ever a patient of mine when I was on the team at Princess Margaret, I found that this was actually very, very helpful. I live by the KISS principle. If anybody knows, the KISS principle is keep it simple, stupid. And I'm only referring to myself, of course. But these are sort of the five main things that we were looking at in clinic through blood work and other diagnostic testing. And the heart in the middle is the patient, because without actually seeing the patient and seeing what the how the patient is looking, it's really irrelevant on what their blood work their blood work might look fine, but they're really feeling so awful. So it's important that we always take a really good look at the patient. And we're going to just talk a little bit about what we do when our complete blood count comes back. We're going to talk a little bit about bone health, organs, specifically really looking at kidney function. And Dr. Reese is going to help explain further on monoclonal protein and light chains. So I spoke last month on hemoglobin, and myeloma patients I found became experts very, very quickly after they were diagnosed. So just as a reminder that our hemoglobin carries red blood cells. Red blood cells, our hemoglobin is made up of red blood cells, and red blood cells carry oxygen. So when we are anemic, regardless of the reason for our anemia, when we have anemia, we are often fatigued. We may feel dizzy, experience shortness of breath, feel quite chilly. Sometimes it gets so bad that people will complain of chest pain. And that's because our tissues are not getting into the tissues. So what interventions are available for patients with low hemoglobin? That when you have multiple myeloma, people become anemic both because of the illness and also because of the treatment for the illness. So it's really something that many patients with myeloma experience. With myeloma, we may use a medication. You often will hear the medication Eprex. And Eprex is a subcutaneous injection, which is something given under the skin. There's also Aranesp, which is another subcutaneous injection given under the skin. Both of these medications will help the bone marrow produce more red cells. So as long as the myeloma isn't really out of control at this point, and the marrow isn't too packed with myeloma, either of these medications can be very helpful by stimulating the bone marrow to produce more of the red blood cells to carry hemoglobin. The other thing that we see very, very often in myeloma is patients requiring blood transfusions. Now, I am a relatively elderly nurse at this point. I was a nurse through the HIV/AIDS crisis back in the early 80s, where our blood system really, our blood products really did get contaminated. And people, even to this day, 40 years later, can be quite wary about having blood transfusions. But a blood transfusion is often a very, very important part of the myeloma treatment, because without bringing the red blood cells back up to an acceptable level, patients will become quickly too ill to continue on with treatment. You'll often hear refer to the team as referring to a blood transfusion as a unit of packed cells, and that's just hospital talk for a bag of blood. Frequency and need for a blood transfusion will really be based on two things. First of all, what the hemoglobin is, but also, did the last time the patient received a unit of packed cells or a unit of blood, did it improve quality of life? Did the patient uh, get back to a more normalized hemoglobin level? Did it alleviate some of those symptoms? So we don't just randomly give a blood transfusion. Some people say, well, why can't I just book my clinic visit for every 3 weeks or every 2 weeks? And then I'll just come in and get my bag of blood. No, we really, really need to make sure that the patient requires a unit of packed cells.
Now, and that's where I was, may I make a
Of
comment?
course.
I think that may represent a shift in approach from some of our long-term patients. And I think in one of the first meetings, I talked about when I first started, which was much before you did, we kept the hemoglobin over 100. And then there was data that said 90 is a satisfactory minimum, and now 80, unless the patient is having problems. And there are people whose body adjusts to a hemoglobin of 70. And while the transfusion supply is quite safe, nobody wants an extra transfusion. The other point is EPREX, which is easier for us to titrate than Aranesp, which the kidney doctors like, works about 80% of the time to bring the hemoglobin up without a transfusion. So they may be very important in people if they have other health issues, particularly heart problems, need more gas in the engine. But, a set number is no longer mandatory to keep people safe with the minimal of intervention.
Absolutely. Thank you for that. And and just to piggyback on to what Dr. Reese was saying, it really, I think medicine in many, many areas is certainly more patient focused than it was, in years gone by. The studies that were done about where hemoglobin should be kept, interestingly enough, was actually studies done on joint replacement patients with orthopedic surgeons. And when you're a healthy 62-year-old that needs a knee replacement because you've been playing hockey, you're gonna recover much more quickly than someone who's been undergoing cancer treatment for the last 6 years. So it's really based on, it can be very based on people's need and response. So the next part of the complete blood count is that we'll just talk briefly about that we mentioned last month. There's neutrophils, which are part of our white cells, and neutrophils are very, very important because they help protect all of us, not just myeloma patients, but all of us from infections. So when our neutrophils are low, and when myeloma patients become neutropenic, the risk of infection goes up. So what do we do when the blood work comes back and shows that people are neutropenic? Well, the first thing we need to do is remind patients, and I mean, COVID has been a terrible thing without a doubt, but it did certainly open many people's eyes to the importance of infection control. And as a reminder to everybody online, myself included, always always practice good hand washing, masking when in crowds, or when, when during flu season, when especially during this busy time of the year. And please speak to your clinical team about ensuring that all your vaccinations are up to date. Work with your family physician to make sure that you've had your flu shot, your updated COVID vaccine, your shingles vaccine, all of those things that you can protect yourself even a little bit more. The other thing that's so important, whether the patient is neutropenic or not, is to really keep an eye on yourself or your family member that has myeloma. Do they have a cough? Are they more fatigued? Do they look feverish? Are they just not themselves? And because really, being assessed by the team, especially before going into a weekend, etc., to see, does that person need to start on some antibiotics, etc., before things get out of control. Of course, we don't use antibiotics willy-nilly. We're very cognizant that overuse of antibiotics has certainly been challenging over the past 20 years in medicine. But for myeloma patients, it can be, the difference between a long, even an ICU hospital stay, or getting through something quite easily. Patients with low neutrophils, your clinician, your hematologist, or your clinical fellow, your nurse practitioner, member of your medical team, may prescribe a colony stimulating factor medication, a granulocyte. We call it GCSF, and you'll hear Neupogen, and again, Neupogen is very much works the same way as the EPREX did. We want to stimulate the bone marrow to produce more of these neutrophils in the bone marrow. So these medications are given based on ongoing blood work with close monitoring and review. We don't just put someone on Neupogen or any other medication like this and just sort of leave it and not keep a close eye. So never be surprised if suddenly you or your loved one needs to go on a GCSF. It might be a temporary thing, or it might be something that's around long term, but it can be very, very, very helpful.
If I may make my
Please,
for
please
comment,
do.
don't mind
Absolutely.
going back. If you don't mind going back.
Oh, sure.
There's a new vaccine, and you may have heard about it on media, that the RSV vaccine.
Yes, thank you, Dr.
RSV stands for respiratory syncytial virus, and it's very common in young kids. It causes a type of chest infection where there's wheezing. And we have been aware in our population of RSV for a long time because it can make our adults, particularly those with myeloma, quite ill. So if you've had those unpleasant nasal swabs for viruses, not only COVID, but all viruses like influenza and RSV, we often diagnose it. There is no perfect treatment. For influenza, we have a pill that we give. For COVID, we have a pill we can give. But for RSV, the treatment is supportive, and it may last quite a while. So now there's a vaccine for the very young and those that are older, and it is recommended to have it because RSV can make one quite sick. My mother's 90 years old, lives in Texas, and I spoke to her on the phone just before COVID, and she was breathing heavily, and I had my brother there do an intervention, took her to the hospital, and oxygen was low and she had RSV pneumonia. This was before COVID. So she has no major health problems. She's just elderly. So this is something we're aware of in our clinics, but I don't think we don't talk about it very much. So that's important. The other point I would note is for neutropenia. In contrast to anemia, we have a little bit more of a threshold because there's lots of good data to say, whereas a normal neutrophil count may be 2.5 to 5, once it's less than 0.5, we are really almost a sitting duck for infection. But we aim for a neutrophil count of at least 1 in our patient. That way there's a little bit of a buffer. So if someone, like Suzanne was saying, comes into clinic and their neutrophil count is 0.8, we may want to, on the spot, start granulocyte colony stimulating factor, which is either Neupogen or Grastafil is the other brand name. One of the, I think, better things about Grastafil is for our patients, maybe an injection once a week, sometimes once every 2 weeks, rarely twice a week. It works very quickly. By almost a few hours, the neutrophil's up, certainly by the next day. So if someone's getting chemotherapy for breast cancer and gets neutropenic, they may need daily doses for a week or 10 days. We can often get away with once a week, which from our point of view is easier on our patients. Okay, Suzanne, take it away, please.
Thanks, Dr. Reese, very much. So just moving on with a complete blood count. And again, we discussed platelets last month. We talked about how important it is to ensure that patients do not become too thrombocytopenic. We don't want to have any patients get into a catastrophic bleed. As a reminder, the technical term for low platelets is thrombocytopenia. You might be able to throw that into some sort of game over the holidays, spell that. And again, it's one of those things that many myeloma patients will face during their time with multiple myeloma. Again, the disease itself can cause thrombocytopenia, and many of the treatments that we use can cause thrombocytopenia. Platelets are collected by Canadian Blood Services, as our packed cells are collected by Canadian Blood Services. The difference with platelet infusions is that a bag of platelets will often have 4, 5, sometimes even 6 donors in one bag of platelets. They're very precious for sure. We generally don't infuse platelets, at least at University Health Network, until platelets are less than 10. And it's because the supply of platelets are often so low. So platelets that are less than 10, or when a patient has an obvious bleed of some sort, they have bleeding in their urine or a nosebleed that hasn't stopped all night. Patients may come into clinic and say, I've noticed I've got a lot more bruising and my teeth my gums have been bleeding when I'm brushing my teeth. I mean, these are all reasons to make sure that we have an up-to-date platelet count. Sometimes patients will present in clinic and it looks like they've been in a rumble in the back alley, and the white of their eye it looks like they've actually bled into their eye. And that can be another sign of thrombocytopenia. So any of these things that happen, especially if you're not going to be in clinic for a while, call whoever you call that's on call for you, and your myeloma colleagues at whatever cancer clinic or hospital you're being looked after, and say, listen, I'm a bit concerned. I've had low platelets before, and I've got some bleeding blood in my urine, or I have a nosebleed. I'll reiterate again, and I said this last month, and I'm all about safety and trying to be proactive instead of reactive. Being safe with ambulation, I can't tell you enough how important it is to be careful if you tend to run low with your platelet count. I know nobody wants to use a cane or a walker. I get it, I do. But if you have thrombocytopenia and you fall and you bump your head, it can be the teeniest little bump, and it could be absolutely life altering or even fatal, because you could easily bleed into your brain. So I don't like to be a Debbie Downer all the time, but it's just so important that people understand how important it is to be safe. And if you have someone at home that you love with myeloma and you're worried about their mobility, ask your nurse practitioner, your physician, to see if you can have a home safety assessment through the home care program. An occupational therapist will come out to the home to see what can be done within the home to make it even safer. You'd hate to go through all these trials and of treatment and then fall and bump your head.
I can't, if you could bear with me to
Of
make some
course.
comments about platelets. I can't stress enough how important that is with low platelets and falling. Pride should not be a part of this because falling on one's head, even though people may be holding onto walls or claiming, they're okay, a bruise inside the brain is basically a big stroke, and the bleeding can't clot. It gets bigger and bigger. So it is preventable. Low platelets are quite okay without a stress like being vulnerable to bump or bruise. A couple of comments about the threshold. Again, the threshold where we always transfused used to be 30, then 20, and now without provocation, it's down to 10. Now you may find your team, platelets don't last as long with a transfusion as red cells. Red cells will last 2 to 3 weeks at least in the vast majority before another transfusion is needed, because those red cells live a long time. Platelets, when we make them, a platelet only lives a week, and when they've been collected and collected in a bag and stored in the blood bank and then infused, they may only last 1 to 3 or 4 days. So if they're given, they have to be given more frequently. So if the thrombocytopenia is long-standing, people may get platelets once a week, rarely twice a week if it's severe. And even if the platelets are over 10, it's know your patient and their pattern. If it's Thursday and your patient is needing platelets regularly and the platelets are 12, we're probably going to give platelets to bump them up to get people through the weekend. So there's variability to that I think if hematologists know anything, they know how to manage low blood counts safely. So there are variations. Now, the other thing is if someone's going to have surgery, which happens to people who have low platelets, having a platelet count of 50 is generally quite safe because the blood clots quite normally with a platelet count of 50. Now, if someone's having a catheter put in, that's a very minor procedure like a Hickman or a pick may not even need to be 50. So again, we have a great buffer. Normal platelet counts about 200, but we do quite well till we get down to those very, very low numbers.
Thanks, Dr. Reese.
Thank you.
So a couple of other things that before we move on to Dr. Reese talking about the more complicated blood work, such as monoclonal protein, is, the other thing, excuse me, that we're often monitoring quite closely in patients with multiple myeloma is kidney function. And I've mentioned the last couple of months that myeloma can affect any organ, but it really loves two things more than anything. It loves our kidneys and it loves our bones. So kidney function is important to keep an eyeball on, especially if patients have been sort of struggling with their disease and things aren't that stable. So we monitor kidney function by watching the patient's creatinine. Now, creatinine is not the same as creatine. Creatine is something that bodybuilders put in a drink to build muscle. Creatinine is a value that we watch for kidney function. When you're told by your team how important it is to drink 1.5 to 2 liters of water a day, there's a reason. Because in order to flush out all of the toxins, because that's what kidneys do, they're sort of the kidney and liver, the kidneys and liver, they're a waste depository, if you may, and we need to clean them out. So 1 to 2 liters of water a day. Now, water is best, but uncaffeinated drinks are okay as well, especially if you can see through them. The other thing that we keep an eyeball on is sodium. I've had patients in my practice that have been so compliant, and they have drank so much water, often way more than 2 liters, because they were trying to be the best patient ever. And eventually they just started peeing out all their sodium. And then I told them that my prescription was that they had to go home and either go to McDonald's drive-through on the way home and get McDonald's fries, or a bag of Lay's potato chips. Either of those two things will rectify your sodium level. So we keep an eye on this, and as Dr. Reese will say, and I've said, it's not a one-time value that we're looking at. It's always trends, and an excellent physician clinician will know their patient well and really get to know what the trends are going to look like. Another thing that we keep a close eye on is patients' calcium levels. Elevated calcium levels, especially in the setting of new pain or increasing pain that's already been, around for a while, I'm not saying it does, but it could indicate that there is some bony involvement. And Dr. Reese is going to speak next on going to spend some time talking about bony involvement with multiple myeloma and what can be done. And Dr. Reese, could you be so kind? You will explain this much better than I can. I know that by taking oral vitamin D, patients that are on bone strengtheners such as zoledronic acid or denosumab, that can sometimes change what the calcium levels are in the body and the blood work. Can you speak a little bit to that for me?
Sure. I'll start out with calcium is regulated by the body at a certain level. And it is partially regulated by the vitamin D that we take. When our patients are getting a bone protective agent like Zometa or denosumab or pamidronate, it takes the calcium in our blood and drives it into the bones to keep them strong. So even though high calcium can occur in myeloma when the bones are being dissolved by the disease, our patients often are on supplements of vitamin D when they're on a bone protective or a bone building agent. And many of our patients take 1,000 units a day, occasionally 2,000, and that's appropriate. But just like some very compliant or enthusiastic individuals will drink way too much water, I have had individuals that thought, well, if 2,000 units of vitamin D is good, I'm going to take 5,000 units a day. Well, that can cause elevated calcium. And it's due to vitamin D toxicity, not the disease, but prolonged high calciums damage the kidneys no matter what. So again, these are in a fine balance. And we do measure calcium in our clinic every visit to be sure it's not too low from our bone building agents, and certainly not too high that could be the myeloma. Now, there is a hormone imbalance that's not that rare called hyperparathyroidism. It's the gland is next to our thyroid, but it also contributes to calcium regulation. And so it can be a little over enthusiastic too. And so elevated calciums do not, as Suzanne said, always mean that the myeloma is active. But we use it as a trigger to do the other assessments that we need to do.
I think what all of this shows, and what it will continue to demonstrate as we go further through this particular seminar and into next year is just really how complicated multiple myeloma is, and why it really takes a team of experts to manage these things. It's such a fine balance between, I need vitamin D. Well, now it's summer. Maybe I don't need as much. And my sodium went up and then it went down. And it's I can only imagine how distressing this can be for our patients at times, without a doubt. So I'm going to hand things over to Dr. Reese. I think I'll do the pointer, Dr. Reese. I don't want anything to happen to
I agree. I'm not going to ask for control.
Screen again. So I'll let we were born in the 50s. I think people understand. I'll let Dr. Reese speak to what we do when the monoclonal protein or M-spike comes back from the lab.
Yes, thank you. And again, I apologize for the technical challenges. Anyway, so what do we do if the result in clinic shows that the M spike has gone up? And I've shown here a normal serum protein electrophoresis. You don't see that in your lab result. What you are going to get a report of is on the SPEP with an M spike. You can see instead of the gamma region being a little bump representing all the antibodies in the body, and they're good and at the right level, there is one big spike that is the monoclonal protein tumor marker. It's one antibody. But the machine that measures this, we call it an instrument, can't quite give the same reproducible number every time. It's an indirect measure. It requires some interpretation. So even though our patients, and I get it, the anticipation of, is the M spike going to be higher, lower, the same? It varies. If the patient is stable, it's not going to be 6, 6, 6. It may well be 8, 4, 5, 7, 6, and that causes extreme anxiety. But the problem is not that each visit the disease is a little bit better or a little bit worse. It's a problem with the ability of the test to be absolutely reproducible. So again, as you've heard, the trend is important, and we don't rely on one value to except under the most rare circumstances to change everything. Now, to make the plot a little thicker, most people have IgG class as their monoclonal protein. The second most common is IgA, and the third is just a light chain. It doesn't matter in terms of is the disease better or worse. It's just what tumor marker are we using. IgA can be particularly hard to measure accurately with the serum protein electrophoresis, the SPEP, and the spike is very wide, and so the lab will tell us, this isn't accurate. Measure the total IgA, and that comes in another assay many times done on the same visit on all patients, that you may have a value of your total IgA, IgG, IgM, and we're looking at the total IgA. There will be a little bit of good IgA in there, but it can be much more accurate. So with that said, what are our definitions of myeloma progression? Because there are international consensus criteria to try to make sense of this expected variability and not change treatment when it's not needed, but avoid failing to respond if there is an issue. Next slide, please.
My goodness, that is really complicated. I can only just imagine how many things you and your hematology colleagues have to think through. It's as my grandmother used to say, well, that was clear as mud. It's a real lot to think, a great deal of things to sort of work through. And again, we're so grateful to people like you, Dr. Reese, that can figure all this out.
Well, there's a lot of history behind it, but I do recognize and have always observed the great anxiety with these numbers. And, it's regrettable, because if someone has what we call a solid tumor, breast cancer, colon cancer, there are scans that measure the size of the cancer lump. We call it a lesion or the mass, and the CT scan will give you very precise measurements, and it's not fuzzy borders in the usual, it's either 3 by 5 centimeters, or it's, it doesn't go up a little bit, down a little bit, up a little bit, down a little bit, and then the doctor says, oh, it's the same. So this is I think a unique feature. And I think the other feature is, because we have to watch the trends, that you go to clinic, someone says, oh, it's up from 5 to 7, we're just going to watch for the next month. Well, we want an answer that day. I mean, just to wait a month to know the future, it is a huge stress. And I think in medicine, the example I often think of is, someone has a bad tooth, you pull it, it's fixed.
I'm not on video.
It has to heal, but the problem is gone. Same thing with surgery. If you have a appendicitis, you take out the appendix, it's finished. With myeloma, there's so much waiting, and I think that needs to be acknowledged, that our patients go through that, from what I understand, visit to visit, and lots of waiting. Anyway, go ahead, Suzanne. Did you want to?
No, absolutely. I proceeded. Your next slide.
Thank you. So back to the definition of progression or relapse, we tend to use those terms interchangeably. But when we're monitoring the M spike, the consensus criteria say that the M spike has to go up at least 25%. So if it is 10, it has to go to 12.5 or higher to say it's really gotten worse. And the reason is, I just tried to say, is the SPEP instrument can't tell small differences. And when people have a very low residual M spike, let's say after stem cell transplant, the level's 1, may stay 1 for years. Well, a 25% increase is going to 1.25 grams per liter. Well, that means nothing. So there's a factor built in that it has to go at least up by 5 grams per liter. So if the level is hovering around 1 to 2 to 3, it has to go up to really 6 to be sure it is going up. Now, I'm not going to talk about urine, because in most people we can follow the disease by the serum SPEP M spike or the serum free light chain levels. But some trials we have to follow the 24-hour urine, and the same pertains for the urine electrophoresis. But it's even fuzzier with using free light chain levels, because free light chain levels fluctuate more, even if they're really stable, than the M spike. They go up or down based on kidney function. And to make things even more complicated, each batch of the reagents that are shipped to the labs to measure the free light chain levels have different sensitivities. So the batches are not all, they cannot be standardized due to the nature of the reagent. So we really have to look at the trends. And I have had individuals that when their free light chain, let's say they had kappa myeloma, it went from 50 to 60, that meant something. But I've also had patients in my practice that if the level went from 400 to 500 to 380 to 400 to 650, it was stable. And that is truly maddening. So I think one needs to listen to your provider to get a perspective, and sometimes it just means repeating the free light chain. We also require a 25% increase, but we don't use the ratio, the kappa lambda ratio. We don't use the kappa alone. Just to make it really mathematically tricky, we take the difference between the bad and the good light chain, let's say it's kappa, between the kappa and the lambda, and use that value. And so it has to go up 25%. So as Suzanne said, it with practice, perhaps it's easier to understand, but it's not a straightforward way to monitor a complex disease. So I think if the number goes up and reaches one or both of these criteria to say, okay, the myeloma is active, it is progressing, we describe that as laboratory progression or biochemical progression. It's in the lab tests. But then we want to see, is this rise showing harm? And we go back to what Suzanne was saying. Myeloma loves kidneys, so we want to be sure the creatinine is not showing signs of damage or going up. We want to make sure the hemoglobin isn't going down. We've talked about high calcium can be a sign of active myeloma. And we have a low threshold for re-imaging patients. And you don't have to do it every time there's a change in the number. I think it's fair to say we re-image if someone has a history of their myeloma, particularly damaging the bones, or certainly if there's any new or pain in a previous area that's getting worse. We really want to go look and see if there's more damage. And then a decision is made for adjusting treatment. Next slide, please. Now, management is extremely individualized. It's a heterogeneous disease. No patient is exactly the same as another. And so I'm just going to give broad types of options, but this is the choice. Like if you go to the bottom bullet, really depends on so many factors. The type of myeloma, the pace of the disease, what drugs are approved and funded for a given situation, what is the best match in terms of a patient's ability to get to clinic for injected drugs versus only oral drugs, frequencies of visits, side effect profile. But to go through the broad options, on occasion, if there is just a biochemical or a lab increase in the M protein, and there are no other signs or symptoms of myeloma damage, and the rise is very slow, we will occasionally just observe patients. Now, this is a decision made with our patients. And I would say the most common situation is if someone's on Revlimid maintenance after stem cell transplant, and let's say their myeloma diagnosis only caused anemia. And there's a type of myeloma we see, it's not really published, that only has anemia, but the M spike will be very high. There's no bone problem, there's no kidney problems. And if those people have a post-transplant M spike of 1 and no anemia, and the number goes to 6 over a year, well, nothing's going to be easier to take than low-dose oral Revlimid. Yes, there's side effects, no doubt, but most of our treatments nowadays have 2 or more commonly 3 drugs, maybe 4 drugs. We call them triplets and quadruplets. That's a lot more visits, a lot more treatment. Now, the risk of that is the myeloma changing between visits unexpectedly, because it can do that too. And you don't want your patient to, we're observing monthly usually, to all of a sudden have a bone lesion. And I would say with the newer treatments, we're doing this less often, but it can tide people with a certain biology through quite a few months or occasionally years. Another approach we did quite commonly, again, with the newer drugs coming out, which we will be talking about in our future sessions, particularly the ones available through access programs and trials, we're sort of moving to switching to these newer agents sooner than perhaps we did with the older ones. But still, sometimes we'll have a patient on one drug, and when the disease progresses, we'll either add something to it, like in the case of Revlimid maintenance. Sometimes we'll just add dexamethasone and Velcade. So now the individual is on RVD. Now, why do we do that? Why don't we change everything? Way back in the first meeting, which was way too complex, I think, people with myeloma have 5 to 7 subclones of their disease at diagnosis. And most of the time when the disease progresses, it's just 1 or 2 of those subclones. The others may still be under control, let's say with Revlimid maintenance. So you can keep the Revlimid and just try to contain the bad guys that have broken through. Another example is if someone's on Cybor-D, cyclophosphamide, Velcade, and Dex. maybe we'll just change the cyclophosphamide to another pill, pomalidomide, so the patient's on PVD. It still can be very useful, but now we have these new drugs. And as a general rule, there's a strong preference for when the disease progresses to be sure our patient has a CD38 monoclonal antibody treatment. We have 2 on the market and approved in different circumstances with different partner drugs. We have daratumumab or Darzalex and isatuximab, also known by the brand name Sarclisa. And as you're probably aware, clinical trials are offering even newer drugs, so-called the BiTEs. These are different antibodies that are now in trials as for the first recurrence, rather than after 5 or 6 or 7 treatments, as in the initial experience. There's also, we have a trial with a very potent type of IMiD, now called the CELMoD, that is a cousin of Revlimid or pomalidomide, much more effective as a pill, not a lot more toxicity. It has the diarrhea of Revlimid and pomalidomide and neutropenia, but is really quite well tolerated and is a very, very useful drug I think we'll see in the future. But again, the choice of treatment depends on many factors. And when you're sitting next to someone in the clinic and they have one drug, it may well not have been the best fit for you. So please discuss the options and possibilities with your healthcare provider. Next slide.
And luckily, Dr. Reese, in the new year, we'll have more time. I'm just cognizant of the time here. We'll have more time to talk specifically about all these wonderful drug opportunities and treatment modalities in the new year. I'm going to move you on to your next slide if you don't mind.
Absolutely, and I'll go fast, and we can do
No,
this
we're good. We're good.
So I'm going to talk about how do we manage bone lesions. I think we talked before that the lesions are thin areas in the bone. They look like holes. They're just thin areas, and they can hurt, or they weaken the bony casing, the cortex, and they can break. Radiation therapy is very useful for pain in a bony lesion, and it zaps the myeloma right where you point the beam, and it promotes healing. It does take at least a couple of weeks for the pain to resolve and a bit longer for healing, even though the imaging does not normalize. One of the, I think, more favorable aspects of myeloma is we do not need big doses of radiation, like some cancers need 5, 6, 7 weeks of treatment Monday through Friday. We can get away with 10 doses, or if someone has the need or very severe transportation difficulties, you get almost the same benefit with a single dose to a lytic lesion. Now, since our bones provide our skeletal framework, if the thinning area or the lytic lesion is in, for instance, where the arrow points, a weight-bearing bone, this is our thigh bone, with normal activity, it can just break. And when we see lesions in these weight-bearing bones, our radiologist will alert us that it looks like it could be at risk of fracture, and we'll have a discussion behind the scenes with the radiation therapist, the orthopedic surgeon, to see if radiation alone will be sufficient, or we need to prophylactically stabilize that bone. And although the x-ray next to it looks a bit grim, once you put a rod in it, then you can radiate, and that weight-bearing bone is going to be stable, and people recover very quickly from these bone procedures. Pain medicine is absolutely essential for these types of processes. And again, if someone isn't on a bone agent, it needs to be started, restarted, or potentially increased in frequency. My last topic is just on the important issue of vertebral compression fractures. If you can go back really quickly.
All right.
Well, maybe you didn't. So we can give radiation to a compression fracture, and the example is shown there where there's this what we call wedge. Compression usually happens in the front of the vertebrae, and that's why people are bent forward, and they are extraordinarily painful most of the time. People say that when they lie perfectly still, there's no pain, but any movement in the severe case is accompanied by muscle spasms on the straps going down our back on either side as it tries to stabilize it. Radiation will accelerate healing, but again, it may take 2 to 4 weeks for the radiation effect to take care and improve the pain. But we have these remarkable procedures, vertebroplasty and kyphoplasty, that really have revolutionized management of compression fractures, be it from myeloma, another cancer, or just osteoporosis, which can also cause this debilitating problem. Next slide, please.
And I'll just, as you go forward, and I want to thank you for bringing up the whole topic of pain management. You know, as someone who apparently I've been considered a pain management expert for quite some time over my career, and there's, you know, unfortunately, opioids have got a bad rap over the last few years, and we, you know, there was an opioid crisis without a doubt. But there are certainly appropriate pain medications for all Canadians that need it. And I look forward to next year to spending some time with our audience talking about pain management, both with pain that's connected to bony involvement, but pain related to other issues around myeloma, because pain medication is not necessarily the evil thing that people often seem to think it is these days. So thank you for that, Dr. Reese.
Yes, and just to add to that, one does not prescribe pain medicine willy-nilly, and there are adjuvants that can help that are not opioids, but particularly with compression fractures, it's almost impossible to get by without some pain medication. And it's important to keep moving, because when we are not active, calcium leaches out of our bones, no matter what the cause of our immobility, and our bones get thinner from inactivity, and our muscles decondition, our muscles get weaker. So I think, in my own view, it's much more important to accept some opioids with careful monitoring and move than absolutely not move and avoid pain medicine. Now, in some centers, all myeloma patients are referred to palliative care, because the proper name is palliative care and symptom management. And that's where the pain experts come in. So we had Suzanne that we could refer to as a pain management expert. Some teams have exclusively a pain management team, but there is an art and a science to it. So I'll just speak briefly about vertebroplasty, which was the first invention, and then more recently kyphoplasty. So vertebroplasty, this is done under a very light general. It's outpatient. People go home afterwards, and an expert, either an orthopedic surgeon, a neurosurgeon, or an interventional radiologist who's trained, has the patient lie where their back is exposed puts a needle into the vertebrae that's squished and slowly injects some bone cement. And this stabilizes the bone. And it's about 80% effective in resolving or markedly improving the pain and the muscle spasms. What has replaced it, if possible, now the person doing the procedure will decide which vertebrae is better for vertebroplasty or kyphoplasty, but I know we have, I think, one of Canada or North America's specialists at Toronto Western who has said prefers kyphoplasty because what it does, it's similar, puts the needle in, threads a balloon into the vertebrae, slowly inflates the balloon so it raises up the borders of that collapsed vertebrae, removes the balloon, and there's a space that remains for a while. The needle's still in, and you put the cement in this space, and you get some restoration of height. So posture's better, that leaning forward is better. It is done for pain. It's not done just to give a centimeter, but our expert I have seen do 10 levels at one time, 12 levels at one time of the whole backbone in someone whose spine had collapsed completely. So we don't see people bent 90 degrees anymore, like I saw when I first started at Princess Margaret over 20 years ago, where there was just, you know, irreversible damage to the spine. So I mean, the are occasions where people have this done, get up off the table, and their pain is much, much better. So that's really cool. And my last slide is just says that sometimes if there is too much damage to the spine, or if the myeloma is grown outside the vertebrae and is pressing on the spinal cord, more major surgery is done, and actually hardware is put in to reconstruct the spine again. And nowadays it's so sophisticated. The final picture has where someone has both hardware put in and vertebroplasty or kyphoplasty to rebuild the spine. And these are really remarkable procedures. Next slide, please. So I think I've been asked to close this meeting, and Suzanne and I would like to thank you greatly for your attendance and your patience with our technical issues. We won't have a seminar in December because of the busy holiday season, but in January, Suzanne's going to do one on her own and talk about important non-scientific issues that are relevant for everyone living with this disease in terms of the family impact, self-care, issues about diet, lifestyle. In other words, living with myeloma with the best quality of life possible. And then we'll be back together in February, and we'll focus more on treatment options and management of side effects. And finally, we really wish at CMRG, all of us, to wish you and your family a joyful holiday season. Again, we welcome your feedback. These topics and sessions are for you, and you can email or contact Suzanne, who will quarterback questions, and we will take note of your feedback so we can be as relevant as possible for you. So I will leave it up to Suzanne and the others about if we have time for questions, because
Absolutely. There was, Dr. Reese, there was a question that came in the chat early on for the, and I'll read it to you. It's from Susan. And the question was for the doctor for later. This came in right at the beginning of our talk. And the question is, and I don't, certainly something that you may be able to address. All of my immunoglobulins are below normal levels. What does that mean?
well, one of those, either IgA or IgM in myeloma, is the class of the tumor marker. So low is good for the point of view for myeloma control. The implication is, though, there isn't a lot at all of, let's say, if it's IgG, there isn't good IgG that's being made. And there isn't good IgA or IgM. Now, that is probably mostly a side effect of the treatments. And some of the new, very potent myeloma drugs knock down all the plasma cells that make antibodies, the good ones and the bad ones, so that the person's system is not making much antibody at all. So the good news is the bad ones inhibited, but the good ones are inhibited too. Now, in some people, that doesn't seem to cause much problems. I've had people in my practice that they have IgG myeloma, and their IgG is 1, their IgA is 1, and their IgM is less than 1, and they don't seem to have problems. But other people may have recurrent infections or easy infections. And in those people, your doctor or nurse practitioner may consider giving replacement antibodies, gamma globulin, where they can be given once a month intravenously. It's other people's healthy antibodies to serve as circulating factors to try to neutralize the bugs that are trying to get in our system. They can also be given subcutaneously. So it sounds like a good remission if the myeloma is IgG or IgA, but a suppression of the good antibodies, likely from one of the modern treatments.
Thank you for that. I don't see any hands up. Feel free if there's anybody online. Oh, hang on, we have some more
And
questions.
I have one here from Sandra that was sent by email. So
Okay,
why don't you go ahead?
I'll go ahead here. So Robert has asked, why is kyphoplasty restricted to pain remediation if it might also improve quality of life? I can take that one if you'd like, Dr. Reese.
Go ahead.
I think thanks to that question, I don't know that kyphoplasty or vertebroplasty is restricted to pain remediation. I certainly have had patients that have had height loss, and on film, on investigations, we can see that they do have some a vertebral collapse without pain. I think the reason that we see it most often in people that have pain, Robert, is because that is our sort of our first sort of cue that something is going on. So my suggestion, wherever it is that you're being seen, that if you have had height loss, and your posture is bad, and that you've had some vertebral collapse, ask to have a referral. Always be bold. Ask your provider. Say, I would really like to see someone, to have a referral about, to see if kyphoplasty is something that could assist me. I hope that's helpful. you know, there are very few people that I've ever come across, especially through our Toronto Western guy, Dr. Roger Smith, that you know, he did at least do a consult on. So absolutely. I hope
I
that answers your question. Here's
yeah,
Dr. Reese.
yeah, I think what you've said is completely true. Um, I think the reason is a little bit more dogmatic. The procedure is approved and funded. It is the devices that are used are quite expensive. It was a huge fight to get the province to pay for for vertebroplasty, and kyphoplasty is even more expensive. It's not the doctor's time, it's the kit and the devices to do it. And it is approved just like a drug is approved for a certain reason, and that reason is for pain. Now, you know, there, so I think the best thing to do is see a consultant, explain the situation, and I can assure you everyone wants to help, but it's like you can use a certain drug only in one circumstances, but I think you get the picture.
We've had a lovely note here from Wendy, a superb webinar. I've learned so much. Thank you, Dr. Reese and Suzanne. Looking forward to next year's webinars. Sonia says, thank you. Have a great holiday. And then Dr. Reese, you said someone had sent you in an email?
Yes, this is from Sandra, who could not join, but had a question about a recent full body CT scan. That and that some centers are doing that rather than a PET, or certainly the old skeletal survey is not as useful or as used as it once did. And it was to assess lytic bone lesions, and the impression said multiple lytic lesions throughout the skull, ribs, pelvis, and spine, no significant change compared to previous. And what does that mean? And that's exactly the point, that these lesions don't heal. They're still there on the imaging, but they haven't grown. So that would be interpreted as no sign that the myeloma is causing more bone damage. And that's a good thing. That's as good as it gets. Occasionally you'll see a little bit of filling in of the lytic lesions, or there'll be something called the rim will look like it tried to heal, but they don't fill in and heal like a broken bone would in the absence of myeloma in the bone. So that's a good thing, even though it's like scar. They're war wounds left over from when the disease was active, caused its damage, and it's not causing any more damage.
Absolutely. Had another nice note from Yolanda. Thank you so much, Dr. Reese and Suzanne. These seminars are so valuable. Happy holidays. Thank you so much for that. It looks like we've lost about half our participants. The people have gone off to make their dinners or go home from work. If there isn't anybody else and any other questions, I'm going to stop recording the session now. Oh, wait a second, Wendy. Here, we've got another note. Wendy, if you have a vertebral compression leading to thoracic fusion surgery, how often should you have imaging? I have been in remission for a year now.
You know, the indication for regular imaging is not certain. I think, and this was established when people had a different cancer called lymphoma that's in the lymph nodes. People used to do CT scans every 3 months for a year, every 6 months for a year, every year, and there were good studies that said that didn't make any difference. So once these symptoms are gone, if the myeloma stays in remission, we're not going to get a lot of information if there's no change in pain, there's no change in the myeloma tumor markers. And we don't always do annual scans. The CTs and regular x-rays are some radiation. It's not massive, but again, if we don't, we're unlikely to pick up new lytic lesions if everything else is perfectly stable. So we may not want to re-image unless there's a problem.
Excellent. Well, once again, thank you all so much for sticking with Dr. Reese and I right to the very end. Thank you for allowing us into your homes and into your offices and wherever you may be. Happy holidays to all of you and yours, regardless of what you may or may not celebrate. And enjoy your families, and we certainly hope that you have good health through the holidays, and that you have the best quality of life possible. Again, I will see you on my own in January. Please keep an eye out on the CMRG website. Again, I apologize, Dr. Reese, and I apologize for our technological non-prowess might be the right word, but we do try, and we're so grateful to you all. So if you're driving now, safe home, and we'll see you in the new year. Good night now.
Thank you all, and happy holidays and New Year. Thank you very much.